Hello guys, this is Purnima. Today I am going to present pharmacological plan for hypertension. And coming to the introduction, blood pressure is best regulated through the diet before it reaches the stage of hypertension, and there is a wide range of treatment options. Lifestyle adjustments are the standard treatment, and people with BP higher than 130/80 may use medication to treat hypertension, and the choice of drug depend on the individual or patient, and eventually a combination of two or more antihypertensives can be used. And coming to the classification of hypertension, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, diuretics, alpha blockers, alpha beta blockers, central sympatholytics and vasodilators. And coming to the class angiotensin converting enzyme inhibitors, examples include captopril, enalapril, lisinopril, etc. And ADRs include cough, rash, taste disturbance, renal failure, angioedema, and contraindicated in pregnancy, renovascular disease. And coming to the dose of captopril, initial dose was 25 mg per oral and 8 to 12 hourly, increased gradually based on response. Maintenance dose was 25 to 150 mg per oral, it was given 8 to 12 hourly, and maximum dose was 450 mg per day. And coming to the doses of enalapril, initial dose was 5 mg per oral once daily, and maintenance dose was 10 to 40 mg per oral once daily, or it can be given in 2 divided doses. And maximum dose of enalapril was 40 mg per oral once daily. And coming to the mechanism of action of angiotensin converting enzyme inhibitors, generally it means normally renin, which is released by the kidney, act on angiotensinogen which is present in liver. Renin converts angiotensinogen into angiotensin 1. Angiotensin converting enzyme which is present in lungs convert angiotensin 1 to angiotensin 2. Angiotensin 2 go and binds to angiotensin 2 and angiotensin 1 receptor. Angiotensin 2 is a potent vasoconstrictor, and it also stimulates the release of aldosterone from the kidney. And pharmacologically, by giving ACE inhibitor drugs, we block the enzyme ACE, so there is no production of angiotensin 2. So angiotensin 2 doesn't go and bind to angiotensin 2 and angiotensin 1 receptor, so there is no vasoconstriction and there is no release of aldosterone, so there is a decrease in blood pressure. And coming to the pharmacokinetics, of captopril were 70% of orally administered captopril is absorbed, and bioavailability of captopril was 70%, time to peak action 1 hour, elimination t-half 2 hours, mode of excretion renal, duration of action 6 to 12 hours. And enalapril pharmacokinetics were bioavailability 50% and time to peak action for 4 to 6 hours, elimination t-half 11 hours, mode of excretion renal, duration of action 24 hours. And coming to the next class, angiotensin receptor blockers, examples include telmisartan, losartan, valsartan, etc. ADRs of angiotensin receptor blockers include renal failure, edema and headache. And angiotensin receptor blocker drugs contraindicated in pregnancy, renovascular diseases. And coming to the dose of losartan, initial dose was 50 mg per oral once daily, maximum dose was 100 mg per oral once daily. And coming to the doses of pediatrics, in pediatrics 6 years or older, initial dose was 0.7 mg per kg per oral once daily. And coming to the dose of telmisartan, initial dose was 40 mg per oral once daily, maintenance dose 40 to 80 mg per oral once daily. And coming to the mechanism of action of angiotensin receptor blockers, and we are going to bind AT1 receptor, so there is no binding of angiotensin 2 to angiotensin T1 receptor, so there is no vasoconstriction, decreased aldosterone secretion, catecholamine release, and decreased cell growth, decreased blood pressure. And catecholamines include, it is generally released from adrenal medulla. Examples of catecholamines were epinephrine, norepinephrine and dopamine. And it is the pharmacological action of angiotensin receptor blockers. And pharmacokinetics of losartan, Bioavailability of losartan was 33% due to first pass metabolism. Peak plasma level 1 hour, protein bonding 98%, excretion kidney, T-half 2 hours. And coming to the pharmacokinetics of telmisartan, peak action 3 hours, action lasts greater than 24 hours. And coming to the next class, calcium channel blockers. Calcium channel blockers are classified into two types, dihydropyridines and non-dihydropyridines. Examples of dihydropyridines include amlodipine, felodipine, etc. Non-dihydropyridines examples include diltiazem, verapamil, etc. Coming to the idiots of dihydropyridines, flushing. Flushing means red and hot face. Edema, accumulation of fluid. Postural hypertension means it is also called as orthostatic hypertension. Orthostatic hypotension means lowering of blood pressure suddenly when you are sitting or standing, and headache. And coming to the idiots of non-dihydropyridines include bradycardia, decreased heart rate or heart block, constipation. And non-dihydropyridines are contraindicated in heart failure and heart block when used along with beta blockers. And coming to the doses of amlodipine, initial dose of amlodipine was 5 mg per oral once daily. Maintenance dose of amlodipine was 5 to 10 mg per oral once daily. Maximum dose was 10 mg per day. And pediatrics dose of amlodipine were for 6 to 7 years old. Maintenance dose was 2.5 to 5 mg per oral once daily. Maximum dose was 5 mg per day. And coming to the dose of felodipine, initial dose was 5 mg per oral once daily. Maintenance dose was 2.5 to 10 mg per oral once daily. Pediatrics dose, initial dose was 2.5 mg to 5 mg per oral once daily. Maintenance dose for pediatrics was 2.5 to 10 mg per oral once daily. Mechanism of action of calcium channel blockers include calcium channel blockers inhibit the intracellular calcium influx. So there is a decreased concentration of calcium in the cells. Thereby smooth muscle contraction inhibition. There is no contraction of blood vessels, so peripheral vessel dilation and coronary artery are also dilated. Both vessels are dilated. By dilating of peripheral vessels, there is a decrease of peripheral vascular resistance and thereby blood pressure decreases. It helps in the treatment of hypertension, and angina treatment was also represents here. By dilating of coronary arteries, coronary blood flow was increased, leads to decreased O2 supply in myocardium, so it helps in angina treatment. And by inhibiting intracellular calcium influx, LV contraction and heart rate decreases, thereby O2 consumption in myocardium decreases. It again helps in angina treatment. And by blocking calcium channels, we can also provide arrhythmia treatment. By decreasing ICS excitement, we can provide arrhythmia treatment. And coming to the pharmacokinetics of calcium channel blockers, it is water soluble and photostable and has a long half-life of 35 to 50 hours. Amlodipine is slowly absorbed. Its absolute bioavailability is high and it is extensively metabolized in liver. The long half-life is associated with the prolonged duration of pharmacodynamic action. And coming to the next class, diuretics. Diuretics generally divided into three types: thiazides and loop diuretics and potassium sparing. And there is also another class which is carbonic anhydrase inhibitors. Examples of thiazides include hydrochlorothiazide, chlorthalidone. And examples of loop diuretics include furosemide. Potassium sparing diuretics examples were spironolactone amiloride. And examples of carbonic anhydrase inhibitors include acetozolamide. And coming to the ADRs of thiazides were hyperkalemia, decreased potassium levels. Gout, it is an abnormal metabolism of uric acid, so there is an accumulation of uric acid in body. Glucose intolerance, abnormality in glucose levels, hyperlipidemia. And coming to the ADRs of loop diuretics, impotence. And coming to the potassium sparing ADRs, uremia, dehydration, hyperkalemia, gynecomastia. Hyperkalemia is increased potassium levels. Gynecomastia is development of breast in males. And contraindicated in patients having gout. And coming to the doses of hydrochlorothiazide, initial dose was 25 mg per oral once daily. Maintenance dose, it may increase to 50 mg per oral once daily. It can be given in 2 divided doses. And coming to the pediatric dose of hydrochlorothiazide for less than 6 months, children up to 3 mg per kg per day or orally in 2 divided doses. And coming to the dose of chlorothalidone, initial dose was 25 mg per oral once daily. Maintenance dose was 25 to 100 mg per oral once daily. Maximum dose was 100 mg per oral once daily. Furosemide doses were, initial dose was 80 mg per day, usually divided into 2 divided doses per oral. And coming to the dose of spironolactone, initial dose was 50 to 100 mg per oral once daily or in 2 divided doses. And coming to the mechanism of action of diuretics class. And firstly we are going to see the mechanism of action of thiazides. Thiazides generally act at distal convoluted tubule of nephron. It inhibits the reabsorption of sodium into our body. So there is an excretion of sodium. There is no increase in levels of sodium in our body. So there may be decreased fluid volume and decreased blood pressure can be observed. And next class, coming to the loop diuretics, it generally acts at loop of Henle of nephron. It inhibits the Na plus and Cl minus symport. Na plus and Cl minus import. Na plus and Cl minus import. So there is no reabsorption of sodium. So there is no increase in fluid volume. So there is no increase in blood pressure. And coming to the next class, carbonic anhydrase inhibitors. As the name indicates, it inhibits the enzyme carbonic anhydrase, which helps in the formation of H2CO3 from H plus and HCO3 minus. Na plus uses HCO3 minus to reabsorb into our body. By blocking carbonic anhydrase enzyme, there is no HCO3 minus ions, so there is no reabsorption of sodium ions into our body. So sodium ions excreted from our body. So there is decreased sodium levels and decreased fluid volume and again decreased blood pressure. And coming to the next class, potassium sparing diuretics, it inhibits sodium and potassium antiport. So there is no reabsorption of sodium into our body. Again there is no increase in fluid volume. We can observe decrease in blood pressure. Generally potassium sparing diuretics are not used to decrease blood pressure, but it used in combination with other class of diuretics when there is an ADR like decreased potassium levels. Generally potassium sparing diuretics generally increases potassium levels in our body. So it gives in combination with other drugs to increase potassium levels in our body along with antihypertensive effect. And coming to the thiazides, thiazide type diuretic should be used in drug treatment for most patients with uncomplicated hypertension. It can be used either alone or in combination with other drugs. And certain high risk conditions are compelling indication for the initial use of other antihypertensive drug classes. Other drug classes were angiotensin converting enzyme inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers. Most patients with hypertension will require 2 or more antihypertensive medications to achieve goal BP. And if goal BP is more than 20 by 10 mmHg, if BP is more than 20 by 10 mmHg above goal BP, therapy should start with 2 agents, and among that 2 agents one should be the thiazide type diuretic. And coming to the first line drugs, generally thiazide type diuretic, AC inhibitor, angiotensin receptor blocker or calcium channel blockers are considered as primary first line agents, and beta blockers were previously considered as first line agents, but now they are preferred for compelling indications or in combination with one or more antihypertensive drugs without a compelling indication. It can be used alone in compelling indication or in combination without compelling indication. And according to the JNC guidelines, thiazide type diuretics is the primary line agent used for hypertension. But according to AHA 2007 guidelines, thiazide type diuretics were not preferred as first line agent. Generally, AC inhibitor, ARP, CCP considered as first line therapy for hypertension according to AHA. But according to JNC 7, thiazide diuretics were considered as first line therapy. And this recommendation is specified based on reductions in CV morbidity and mortality. As I said before, beta blocker based antihypertensive therapy was not that much effective. So beta blocker is not effective than AC inhibitor and CCB. And coming to the pharmacokinetics of loop diuretics, bioavailability was 60%, highly bound to proteins, excretion bile, T-half 1 to 2 hours. And thiazides, coming to the pharmacokinetics of thiazides, onset of action 1 hour and well absorbed orally, duration of action 8 to 48 hours, and most of it is excreted as such. And coming to the pharmacokinetics of potassium sparing, bioavailability is 70%, T-half 1 to 2 hours, metabolism in liver. And coming to the next class, beta blockers. Examples include acebutolol, metoprolol, propranolol, etc. And coming to the areas of beta blockers, tiredness, reduced excess tolerance, bradycardia, that means increased heart rate, cold peripheries, it means hands and legs become cool, and claudication. And meaning of claudication was by obstruction of arteries, there may be decreased blood flow to the legs, and wheezing, cardiac failure and impotence, contraindicated in asthma, COPD, heart block patients. And beta 1 receptors are present in heart, beta 2 receptors are present in lungs, skeletal muscle, beta 3 receptors are present in intestine. And coming to the classification of beta blocker drugs, it is divided into 3 classes: non-selective beta blockers, selective beta blockers. Beta blockers divided into 2 classes: non-selective beta blockers and selective beta blockers. Again, non-selective beta blockers were divided into 3 subclasses. One is without intrinsic sympathomimetic activity. Examples include propranolol, sotalol, timolol, etc. And next subclass of non-selective beta blockers was with intrinsic sympathomimetic activity. Examples pendolol. And next third subclass of non-selective beta blockers was with additional alpha blocking activity. Examples include labetalol and carvedilol. And next class of beta blockers is selective beta 1 blockers. Examples include metoprolol, atenolol, acebutolol, bisoprolol, esmolol, etc. And coming to the dose of acebutolol was, initial dose was 400 mg per oral once daily or in 2 divided doses. Maintenance dose was 400 to 800 mg per oral once daily. And coming to doses of metoprolol, initial dose was 100 mg per oral once daily or in 2 divided doses. Maintenance dose was 100 to 40 mg per oral once daily. And coming to the pediatric doses for metoprolol, initial dose was 1 mg per kg per oral once daily. Maximum dose was 2 mg per kg per oral once daily. Coming to the mechanism of action of beta blockers. Beta blockers are also known as beta adrenergic blocking agents. And beta blockers works by blocking the effects of hormone epinephrine, also known as adrenaline. When you take beta blockers, heart beats more slowly and with less force, thereby reducing blood pressure. And coming to the pharmacokinetics, well absorbed orally, low bioavailability due to decreased first pass metabolism and increased with meals, T-half was 3 to 4 hours, protein binding 90%. And coming to the next class, alpha blockers, Examples include prazosin, terazosin, etc. ADAs include edema and postural hypertension. Postural hypertension, also called as orthostatic hypertension. It is decreased in blood pressure when you suddenly sit or stand, and contraindicated in urinary incontinence patients. And coming to the mechanism of action of alpha blockers. Alpha blockers work by blocking the effect of nerves in sympathetic nervous system. This is done by binding to alpha 1 receptors and blocking of alpha 1 receptors in smooth muscles or blood vessels. Alpha blockers can bind both reversibly and irreversibly. Coming to the doses of prazosin, initial dose was 1 mg per oral, BID or TID, twice daily or thrice daily. Maintenance dose was 1 to 20 mg per oral once daily or in divided doses. And coming to the dose of terazosin, initial doses was 1 mg per oral once daily at bedtime. And coming to the maintenance dose, initial dose may be increased as needed, and appropriate usual recommended doses was 1 to 5 mg per oral once daily. And coming to the maximum dose of terazosin, 20 mg per day. Coming to the pharmacokinetics of alpha blockers, bioavailability 60%, effective orally, and high protein bonding, metabolism in liver, excretion in bile, T-half 2 to 3 hours. And coming to the next class of antihypertensive drugs, alpha beta blockers. Examples: labetalol, carvedilol, etc. Labetalol is 5 times more potent in blocking beta than alpha. And coming to the areas of alpha beta blockers were dizziness, lightheadedness, weakness when get up in the morning, drowsiness, dry mouth, constipation, etc. Contraindicated in cardiac failure, COPD, bradycardia. And mechanism of action of alpha beta blockers was this class of drugs decreased blood pressure due to alpha 1 and beta 1 blockage, as well as beta 2 agonism. When drugs bind to beta 2 receptors, there is an vasodilating effect which leads to decreased blood pressure, and relatively high doses of alpha beta blockers can reduce both cardiac output and total peripheral resistance, but heart rate was unchanged. And coming to the dose of labetalol, initial dose was 100 mg per oral twice daily, maintenance dose was 200 to 400 mg per oral twice daily, and maximum dose was 1200 to 2400 mg per day. And coming to the doses of carvedilol, initial dose was 3.125 mg per oral twice daily for 2 weeks, and maximum dose was 25 mg per oral twice daily. And coming to the pharmacokinetics of alpha beta blockers, bioavailability 30%, T-half 6 to 8 hours. And coming to the next class of antihypertensive drugs, central sympatholytics. Examples include clonidine, methyl-dopa, etc. ADAs include tiredness, depression. And central sympatholytics contraindicated in heart block, pregnancy, and in renal impairment patients. And doses include initial dose was 0.1 mg per oral twice daily, and maintenance dose was 0.2 to 0.6 mg per oral once daily. Maximum dose was 2.4 mg per day. And mechanism of action of central sympatholytics were these drugs induced peripheral sympathoinhibition. It means it inhibits the activities of sympathetic system. It results in decreased BP due to blockage of alpha 2 adeno and stimulation of alpha 2 adrenoreceptor in brainstem also results in decreased BP. Pharmacokinetics of central sympatholytics include well absorbed orally, peak of action 2 to 4 hours, T-half 8 to 12 hours, duration of action 6 to 24 hours. And coming to the next class of antihypertensive drugs, vasodilатors are divided into 2 subclasses. First subclass is arteriolar, and second subclass is arteriolar and venous. And coming to the examples of arteriolar, minoxidil, diazoxide, hydralazine, etc. Coming to the examples of arteriolar and venous were sodium nitroprusside. And coming to the ADAs of vasodilators include postural hypertension, edema, and headache. And coming to the contraindication of vasodilators was patients having pulmonary insufficiency, including angina, hepatic diseases, hypothyroidism, and coronary artery disease. In these conditions, vasodilators should not be given. And coming to the dose of minoxidil, initial dose was 5 mg per oral once daily, Maintenance dose was 10 to 40 mg per day. Maximum dose was 100 mg per day. And coming to the pediatric doses for less than 12 years children, initial dose was 0.2 mg per kg per oral once daily. Maintenance dose was 0.25 to 1 mg per kg per oral once daily, and maximum dose was 50 mg per day. And coming to the dose of sodium hydroxide, doses were maximum dose was 10 mcg per kg per minute, pediatric 10 mcg per kg minute. And coming to the next vasodilator, and coming to the mechanism of action of vasodilators. Vasodilator drugs work and shows action by relaxing the smooth muscle in blood vessel, which causes the muscle to dilate. So there is no increase in blood pressure. Dilation of arterial vessels leads to reduction in systemic vascular resistance, which leads to fall in arterial blood pressure. Coming to the pharmacokinetics of vasodilators, well absorbed orally, metabolized in both liver and plasma, T-half 1 to 2 hours, duration of action 12 hours, and combinations not to be used. First one, calcium channel blockers and beta blockers should not be used in combination. It may lead to marked bradycardia, means decreased heart rate, and AV block can occur. And next combination which is not used was vasodilators and alpha blockers. As they both have same action, it leads to synergistic effect. And next combination not to be used was alpha beta blockers and central sympatholytics. As they both have opposite effects, there may be antagonism effect. And newer drug combinations were triple pill. Triple pill include telmisartan, amlodipine and chlorthalidone. Dose of telmisartan was 20 milligrams. Dose of amlodipine was 2.5 milligrams, and dose of chlorthalidone was 12.5 milligrams. Generally, the common combinations used in hypertension treatment are CCB plus AC or ARB. In these two drugs, any one can be used, and plus diuretic. And next combination which is generally used was CCB plus beta blockers plus diuretic. And next combination was AC inhibitor or ARB plus beta blocker plus diuretic. And patients who fail to reach goal BP of with 3 drug regimen called as resistant hypertension, for them 4 drug therapy can be given. And next, newer drugs were inhibitors of phosphopeptidases, aldosterone synthase and soluble epoxide hydrolase, agonists of natriuretic peptide A and vasoactive intestinal peptide receptor 2, and a novel mineralocorticoid receptor antagonist are in phase 2 by 3 of development, which is preclinical trials. And while inhibitors of aminopeptidase A, dopamine beta hydroxylase and the intestinal Na+ and Ha+ exchanger 3, agonists of components of the angiotensin converting enzyme 2 or angiotensin 1 to 7, mass receptor axis and vaccines directed toward angiotensin 2 and its type 1 receptor are in phase 1 or clinical development. They are not yet completed their trials. And compelling indication for use of antihypertensive drug, where antihypertensive drug can be used with other complications for heart failure and for heart failure and hypertensive patient. Beta blockers is the first line agent, and next we can go with ACEI or ARB, and hydralazine, aldosterone antagonist. And next indication was high CAD risk with hypertension. First line agent was beta blockers, and next we can go with ACI or ARB. And hypertensive patient with history of MI in the past can use beta blocker as primary first line agent, and we can later go with ACEI or ARB, and next we can use CCB. And for hypertensive patient with history of stroke in the past, can go with Labetalol as first line therapy, and for diabetes and hypertensive patient we can go AC or ARB for whites as first line therapy, and for normal people thiazides and diuretics as first line agent, and we can go later with CCPs, and for CKD and hypertensive patient we can go with ACI or ARB as first line agent, and we can later go with appropriate diuretic therapy and dietary salt restriction. And effect of race on antihypertensive agents compared to whites, blacks are mostly noted to use thiazide diuretic. Blacks also had higher probability of reporting use more than 2 antihypertensive medications than whites, and use of AC inhibitors, ARBs and thiazide diuretics increased over time for all racial or ethnic groups. And according to JNC 8 hypertension guideline, initial drug treatment options for 60 years or greater than old people with goal BP less than 150/90, we can go with non-black people, go with thiazide diuretic, ACI or ARB or CCB, and for black people we can go with thiazide diuretic or CCB. And also for generally less than 60 years or with goal BP less than 140/90, we can go with the same treatment as with previous I said. And coming to the diabetes with goal BP less than 140/90, again we can go with for non-black people thiazide diuretic, ACI or ARP or CCB, and for black people thiazide diuretic or CCB. And for CKD patients with goal BP less than 140/90, we can go with ACI or ARP as a primary first line agent. And coming to the pregnancy conditions, antihypertensive not to be used in pregnancy were diuretics, AC inhibitors and ARP, non-selective beta blockers, sodium nitroprusside. And antihypertensive drugs which are safer in pregnancy were hydralazine, methyl-dopa, clonidine, and also prazosin, dihydropyridines, cardioselective beta blockers, and ISA. And thanks for listening.